Hello everyone. Welcome back to this series of lectures in neurology. Today we'll be discussing about myasthenia gravis. So let's begin. So what exactly is myasthenia gravis? Myasthenia basically refers to an autoimmune disorder where there is a blocking antibody to the ACH receptor. Right? So there are antibodies to your acetylcholine esterase receptors. Right? So acetylcholine, which is your major neurotransmitter at the synapse, is not able to act on the synapse. Right? It is not able to act on the synapse. Hence, there is flaccid paralysis. There is flaccid paralysis. Okay, so it is an autoimmune disorder where there are antibodies to your ACH receptor, as a result of which the acetylcholine is not able to act on the muscle, and hence there is flaccidity in the muscle. So as the name suggests, it means myo plus asthenia. Asthenia means weakness and myo means muscle. Right? So there is weakness of the muscle in your myasthenia gravis. Right? So what are the characteristic features of myasthenia gravis? So myasthenia gravis predominantly involves the proximal muscles. The myasthenia gravis predominantly involves the proximal muscles. Muscles of the limb girdle are most commonly affected by myasthenia, or you can have variants where you can have extraocular muscle involvement in ocular myasthenia, or you can have your bulbar muscles involved in your bulbar myasthenia, right? But most importantly, it involves the proximal muscles. Okay, two. Myasthenia basically has a feature of element type of weakness, right? Because this is involving your neuromuscular junction. Okay. So this is a disorder where the ACH action on the synapse is affected. So this is affecting your neuromuscular junction, or where the nerve joins the muscle, right? So this results in a element type of weakness. It results in an element type of weakness, or it results in flaccid type of paralysis. There is no spasticity. Okay, fine. The third and the most important feature is that there is fluctuating weakness. There is fluctuating weakness, or there is diurnal variation in your weakness. Right? So there is diurnal variation in your weakness. Okay? So the characteristic feature of any NMJ disorder is the presence of fluctuating weakness or fatigability. It is also called as fatigability, right? So beyond a certain point in time when you are contracting the muscle, there is only a point up to which it can act, after which fatigability sets in and the contraction cannot happen, resulting in weakness, right? So there is fluctuating weakness, diurnal variation and fatigability. So the weakness in diurnal variation, the weakness is more in the evenings. It is more in the evenings. Okay. So there is fluctuating weakness, there is fatigability, there is diurnal variation of the weakness, and it's predominantly involves the proximal muscles, extraocular muscles or bulbar muscles, and it's an element type weakness, right? And myasthenia gravis, another very important point, though it is an element type of weakness, the reflexes are usually preserved until the later stages. Okay, so that is about your myasthenia gravis. Let us look at the demographic features of myasthenia. It's in the 20 to 40-year-old age group, it is more common in females. In more than 60-year age group, it is more common in males. This has a bimodal presentation. So it is more common in females in the 20 to 40-year-old age group, and it is more common in males in the more than 60-year-old age group. Okay. So let us just revise this again. What is myasthenia? This is an autoimmune disorder where there are antibodies produced against your acetylcholine receptors, as a result of which acetylcholine is not able to act at the synapse or the neuromuscular junction, resulting in a flaccid paralysis. The characteristic features are your predominant proximal muscle involvement. There can be extraocular muscle or bulbar muscle involvement, element type of weakness, and flaccid paralysis, fluctuating weakness, diurnal variation, fatigability, where the weakness increases in the evenings. Okay, fine. And it has a bimodal presentation, 20 to 40 years or more than 60 years in age. So let us understand the pathophysiology of myasthenia. So this is basically the structure of your neuromuscular junction. This is basically your structure of your neuromuscular junction. Okay, fine. So acetate combines with choline to form acetylcholine by means of the enzyme choline acetyltransferase or CAT, choline acetyltransferase transferase, and it is stored within the vesicles. So ACH is stored within the vesicles of the neuron at the axonal ends of the neuron in the synapse before it is released, right? Then calcium ion channels are present at the synapse which help in the mobilization of the synaptic vesicles, and ACH is released into the synapse. So ACH is the main excitatory neurotransmitter, right? So ACH is the main excitatory neurotransmitter which is released under the influence of calcium ions which moves inside. Once the ACH is released into the synapse, it acts on your ACH receptor. Can you see here? ACH receptor, this purple here. This purple receptors which are present on the synapse is your ACH receptor. It acts on the ACH receptor. Once it acts on the ACH receptor, it causes stimulation of these group of channels which are your sodium ion channels which help in depolarization of the muscle. So it causes increased inflow of sodium into the muscle and it helps in depolarization of the muscle. So this is your normal synaptic membrane, right? Apart from this, there are also certain other proteins. What are the other proteins which are present within the synapse? You can see that a normal synapse, the muscle membrane, is having dips and curves, and there are certain other proteins which are present like rapsin protein which basically connects the brown color which connects the two ACH receptors. Then you have your DOX7, MuSK and LRP4. These are all proteins which help in keeping the ACH receptors in place, and they also play an integral role in the synaptic function. Okay. Now once this ACH action is done, the rest of the ACH is basically broken down by ACH esterase and it is taken back. It is broken down by acetylcholine esterase and it is made into acetate and choline, and then it is recycled again and it is walked back into the synapse. Okay, fine, clear? So this is about how a normal NMJ functions and how it is compared to a myasthenic person. Now when you compare to a myasthenic person, what are all the changes that you can see? So first is there are blocking antibodies, can you note here, to the ACH receptor. There are blocking antibodies to the ACH receptor, as a result of which the depolarization of the muscle itself doesn't happen. There is no depolarization. There is no depolarization of the muscle, right? There is no depolarization of the muscle. And there can be a presynaptic rundown. That means that over time, as the ACH is not able to act on the ACH receptor, over time the ACH production itself decreases. This is what we call as the presynaptic rundown. The ACH production itself decreases over time, and this results in subnormal activation of the muscle, and hence the muscle will not be activated at all. There is no stimulation. Also, can you see that the synapse is oversimplified? The synapse is oversimplified, right? The undulations are all lost. Okay, the synapse is oversimplified. So this is the basic pathophysiological changes which happens in myasthenia. 55% of the individuals have antibodies to acetylcholine receptor, 40% of the individuals can have anti-MuSK antibodies, and 1 to 3% of the patients can also have anti-LRP4 antibodies. So these two are the other type of antibodies which can be found in myasthenia. Okay, so there is oversimplification of the synapse, there is presynaptic rundown of the ACH, and there is no depolarization of the muscle in myasthenia. Alright, fine. Now why did we speak about these proteins, rapsin, DOX7, LRP4, MuSK? This is because there can be antibodies in 40% and up to 2% of the individuals can have anti-LRP4 antibodies, 40% of the individuals can have anti-MuSK antibodies, And DOX7 and rapsin are involved in congenital myasthenic syndromes. Okay, congenital myasthenic syndromes, you can have rapsin and DOX7 antibodies, right? So this is about the pathophysiology of myasthenia. Now let us look at the clinical features one by one. The most common clinical manifestation is the presence of extraocular muscle involvement, which is characterized by ptosis. Ptosis means drooping of the eyelid and covering of your iris by more than 50%. There is ptosis. There can be diplopia. There can be diplopia or double vision, right? Now, if the disorder is limited to your ocular muscles for 3 years and there is no progression, then you call it ocular myasthenia. Because within 3 years, usually if you have limb girdle involvement, then you can have a generalized myasthenia. Okay. Then there can be facial muscle involvement where you have facial paralysis, and this gives rise to a characteristic myasthenic snarl because they are not able to smile well, and it results in a myasthenic snarl. Okay, this is called as the snarling facies in myasthenia. Then in bulbar myasthenia, how does bulbar myasthenia presents with damage to the bulbar muscles? So you can have dysarthria, you can have dysphagia, you can have dysphonia. So they can present with dysarthria, they can present with aspiration while swallowing, right? You can have evidence of 9, 10, 11 cranial nerve paralysis when you examine them, right? So when you examine them, you can have evidence of 9, 10, 11 cranial nerve paralysis, and this is usually associated with an anti-musk antibody. And the limb weakness we have already discussed. It's predominantly proximal limb involvement. It's predominantly proximal limb weakness, and it shows the presence of diurnal variation. And it shows the presence of fatigability. Okay, fine. And generalized myasthenia, when there is involvement of the extraocular muscle, limb muscles, you can have generalized myasthenia. On examination, there are certain signs. What is peak sign? Peak sign means there is difficulty in eyelid closure. So when you close your eyes, it is very, very weak, and you can see that parts of the sclera are exposed, and eyelid closure weakness is called peak sign. Then curtain sign. What is the meaning of curtain sign? So a myasthenic patient, when you try to lift up one eyelid, the other eyelid goes down even more. In a myasthenic patient, when you try to lift up one eyelid, the other eyelid goes down even more. That is called as the curtain sign. Then sustained upgaze can result in ptosis, because in myasthenic patients the muscle is prone to fatigability. So if you do a sustained upgaze, then the muscle can become fatigued and you can have a ptosis. So even if the ptosis is not very apparent, when you do an examination and you basically put any muscle into a sustained state of contraction, it can go into fatigability, right? So these are the basic signs which are seen in your ocular myasthenia. Okay, in your ocular myasthenia. Okay, fine. Now, let us see how do we diagnose your myasthenia gravis, right? History-wise, this we have already seen: diplopia, ptosis, and ocular myasthenia, dysarthria, dysphagia, dyspnea. Dyspnea can also happen if there is bilateral vocal cord involvement. Then weakness in characteristic distribution, proximal weakness. Apart from that, in your generalized myasthenia gravis, you can have extensor, neck extensor muscle weakness. So you can have a head drop. So in every patient whom you are suspecting to have myasthenia, it is always advisable to look for your neck holding, right? In generalized myasthenia gravis, you can have your neck extensor weakness as well. And fluctuation and fatigability basically means that the muscle symptoms become worse with repeated activity and improve with rest, right? And these are the history-wise features that you can ask for. Physical examination, evaluation of ptosis at rest and after exercise to demonstrate fatigability. Extraocular movement examination, then your strength examination, jaw opening, closure, facial muscles, then weakness following repeated shoulder abduction or proximal muscle hip abduction, and so on. And vital capacity measurement is very, very important, because if there is involvement of diaphragm, myasthenia gravis can involve the diaphragm, especially in generalized myasthenia. in your generalized myasthenia. So if there is involvement of the diaphragm in your generalized myasthenia, you can have respiratory insufficiency and a type 2 respiratory failure. We have learnt about respiratory failure, right? So type 2 respiratory failure basically involves respiratory failure due to muscular involvement, right? So this can result in a decrease in the vital capacity, hence it's very important to measure that as well, because it gives an early sign of respiratory muscle involvement. Diaphragm involvement, respiratory muscle involvement. Laboratory testing. So the first laboratory test that you want to do is the presence of anti-ACH receptor antibodies, which is seen in 85% of the individuals, and in generalized myasthenia especially, and 50% of the individuals with ocular myasthenia. And other antibodies include anti-MuSK, and 2% can have LRP4 antibodies, right? Then 2. You do something called as the repetitive nerve stimulation test, or the RNS. So in your repetitive nerve stimulation test, again you can demonstrate evidence of fatigability. So in your repetitive nerve stimulation, if you give a stimulus, you continuously give a stimulus, so there is a contraction which happens like this, and then the contraction begins to drop and there is no further contraction. So there is a decremental response in your RNS. There is a decremental response, right? This indicates fatigability. This indicates fatigability. So fatigability is seen in your repetitive nerve stimulation. Okay. The confirmatory test, the single confirmatory test that you want to do, if you have to confirm the presence of myasthenia, is a single fiber EMG, which shows the presence of blocking and jitter. So you have a single fiber electromyography which shows the presence of jitteriness and blocking. Okay. There are also certain other bedside tests which you can do. The bedside tests which have been used are your edrophonium test and your ice pack test. Your edrophonium test and your ice pack tests are certain bedside tests used in the diagnosis of myasthenia. So ice pack test, you basically place an ice pack over your extraocular muscle, and after some time the ptosis which is present is going to improve, because on exposure to ice the myasthenia muscles may show improvement. Edrophonium is basically a drug which basically inhibits your, which prevents the degradation of ACH. So edrophonium basically prevents the degradation of ACH, so edrophonium increases the level of ACH in the synapse. It increases the level of ACH in the synapse, thereby it can improvise the myasthenic symptoms. So after giving 2 mg and 8 mg, if there is improvement of symptoms with edrophonium test, then it is highly positive for myasthenia gravis. Okay. So what is the sensitive test? Is your ice pack test. What is confirmatory test? It is your EMG. Okay. And quite highly probable will be your RNS test, which is, if it is a decremental response, it is highly probable for myasthenia gravis. Okay. So this is about the various tests which are used in the diagnosis of myasthenia. Okay. Now, there are certain other antibodies apart from your anti-MuSK LRP4 and your ACH receptor antibodies, which includes striated muscle antibody and Netrin and Caspr2 antibodies. Netrin and Caspr2 antibodies are associated with another disorder which is called as neuromyotonia, which is seen in Morvan syndrome. So, neuromyotonia seen in Morvan syndrome is associated with Netrin and Caspr2 antibodies, which are also seen in myasthenia. Clear? Now, whenever we have an anti-MuSK antibody, always remember that there is no thymus involvement and it is usually pyridostigmine refractory. So, 2 important special points you have to remember about patients with anti-MuSK antibody myasthenia is that there is no thymus involvement, because up to 80% of the individuals with generalized myasthenia do have thymic hyperplasia. So, in anti-MuSK antibody individuals, you can have no thymus involvement and it can be pyridostigmine refractory. Clear? So, what are the differential diagnosis for myasthenia gravis? The most important differential diagnosis is something called as Lambert-Eaton myasthenic syndrome. Okay, Lambert-Eaton myasthenic syndrome. Okay. Here, there is a presynaptic disorder. It is not at the synapse, it is a presynaptic disorder where there is an abnormality or antibodies to the P-type and Q-type calcium ion channels. So if you would just remember the structure of the synapse, there were calcium ion channels here which would stimulate the exocytosis of the neurotransmitters, right? So if this is blocked, then you can have a presynaptic rundown of ACH and you will not have ACH at the synapse. So the basic pathology is different, but the symptoms are similar to myasthenia. Okay, fine. And how do you clinically differentiate your Lambert-Eaton myasthenic syndrome from myasthenia gravis is the presence of absent reflexes, right? So there are no reflexes. I told you when we discussed about clinical features of myasthenia that usually the reflexes are maintained, they are intact, though it is an element type of paralysis. But here there are absent reflexes in your Lambert-Eaton myasthenic syndrome. Then they have severe autonomic changes. So these are the two important clinical differences between Lambert-Eaton myasthenic syndrome and myasthenia gravis. And when it comes to the testing and the repetitive nerve stimulation, what happens is that paradoxically you have a incremental response. So these three are three important features that you have to remember about Lambert-Eaton myasthenic syndrome. Also, it has a malignancy association most commonly seen with small cell carcinoma of the lung, and treatment is slightly different. You use plasmapheresis and IVIG for the treatment of Lambert-Eaton myasthenic syndrome. The other differential diagnosis includes botulism. Botulism also causes flaccid paralysis. And especially it has cranial nerve involvement, so it can simulate a bulbar myasthenia, but botulism will not have the fluctuation which is seen in myasthenia. Then PEO is progressive external ophthalmoplegia, which is a mitochondrial disorder. And the other important DD is hyperthyroidism. Hyperthyroidism can also cause a Graves' disease which has extraocular muscle involvement, and it can cause proximal myopathy as well. So it is an important mimic for myasthenia. Okay, what are the associated disorders? Most important, around 80% of the individuals, especially with generalized myasthenia, have a thymic hyperplasia or a thymoma. Okay, the anti-musk antibody myasthenia gravis does not have a thymic hypoplasia. Then other autoimmune or neurological disorders like CIDP, neuromyelitis optica, Hashimoto's, Graves' disease, SLE, family history of autoimmune diseases, right? Hyperthyroidism, hypothyroidism, and you will also have to ask about drugs that may interfere with therapy like TB, diabetes and so on. So you have to know what are the associations of myasthenia and the tests that have to be done, especially your thyroid function, pulmonary function test, CT chest, MRI and other antibodies for your other autoimmune disorders. Okay, but never forget your thymic hyperplasia. So what are the main drugs used in the management of myasthenia? So first is your anticholinesterase. Why? You do not want your acetylcholine to break down. You increase the acetylcholine levels in the synapse such that it overcomes the antibodies which are present to the receptor. So you give pyridostigmine at a dose of 30 to 60 mg every 8th hourly, because if you miss the dose, the duration of action of pyridostigmine would be only about 4 hours. So you will have to give it at least 3 to 4 times a day, because if you miss the dose, the symptoms will recur. Right? The main side effects are cramps and diarrhea. Apart from that, you will have to give immunotherapy. So if they are presenting with an acute onset, severe generalized myasthenia, or they are present with a myasthenic crisis where there is respiratory muscle involvement, respiratory depression, patient is rapidly deteriorating, then you will have to do a plasmapheresis or give an IVIG. So the main role of plasmapheresis is that it's going to remove the antibodies. It helps in removing the antibodies, right? And IVIG helps in removing the antigen-antibody complexes. Intermediate therapy, if the presentation is intermediate, if it is little subacute, you can give glucocorticoids which are at 1 mg per kg. Long-term immunosuppression is required in myasthenia with MMF, azathioprine or rituximab can be used for long-term immunosuppression in myasthenia. Fine. Now let us look at the algorithm for treatment of myasthenia. So whenever you establish the diagnosis of myasthenia, look for associated conditions that we already spoke, thyroid disorder, other autoimmune disorders and so on. If this is only ocular involvement, right, then you give only pyridostigmine. If this is generalized involvement, you will have to give cholinesterase pyridostigmine. Evaluate for thymectomy because removal of the thymus hyperplasia or thymoma itself can be helpful in many cases of myasthenia gravis. So, what are the indications? Thymoma or generalized myasthenia gravis is with anti-ACh receptor antibodies. That is when you will have to do a thymectomy. Then, evaluate for the surgical risk and do an FPC to see what is their tolerability for the surgery. Right? If the tolerability is good, do a thymectomy and also continue with an immunosuppression in the long term. If the patient is presenting with a crisis, right, then you have to do an ICU management, give Plex or IVIG, plasmapheresis or IVIG, right? So the algorithm is very clear. Lastly, but not the least, never forget the drug interactions with myasthenia gravis. Remember to go through the drug list carefully. So the drugs that may exacerbate myasthenia include antibiotics like aminoglycosides, quinolones and macrolides. Antibiotics like aminoglycosides, quinolones and macrolides. Non-depolarizing muscle relaxants. So whenever you take a myasthenia gravis patient for surgery or you put them on a ventilator, be careful with what kind of a muscle relaxant you are using. Non-depolarizing muscle relaxants will worsen it, like your vecuronium, atracurium, pancuronium and so on, right? So be careful with what sort of a muscle relaxant you are using. Beta blockers and local anesthetics, quinine derivatives, magnesium and penicillamine, checkpoint inhibitors, all of them can worsen your myasthenic symptoms. Then, what are the other drugs which have important interactions, right? So, this can lower the level of drugs used in the treatment. For example, cyclosporin, tacrolimus and azathioprine. If azathioprine is used with allopurinol, it can cause myelosuppression. Right? So, please remember the drugs that are going to exacerbate the symptoms. Antibiotics, quinolones, macrolides, aminoglycosides, beta blockers, non-depolarizing muscle relaxants, quinine, magnesium, penicillamine. Okay? Clear? Right? So, with this, we have come to the end of our chapter on neuromuscular junction disorders, which is myasthenia. Thank you.